Okay, so I want to talk about drug-induced ototoxicity. Namely, what are the drugs that can cause ototoxic damage to the cochlea, for example. So let's first start with what are the factors that can influence if how much a medication will be ototoxic, namely toxic to the inner ear, which has the cochlea for hearing and the vestibule and the labyrinth for equalization, namely for staying stable. So what are the factors of the medication? So dosage, for of course, if we have higher dosage, more harm can be done. Duration of therapy, if the duration is longer, of course the damage will be bigger. Concurrent renal failure, RF, because if there is a renal failure, the drug cannot come out. It should go to the urine throughout the kidney. But if it can't go out, if the kidney is done, the medication will build up in the serum. So chronic renal failure and how severe it is. The next thing is infusion rate. Of course, as the infusion rate is higher, the toxic effect is higher. The next thing is about how long the drug will stay in the body, namely, let's call it lifetime dose. Oh, this is lifetime dose. Oh, I'm sorry. This is how much you got until now. Okay, sorry for not being straight. Okay, so lifetime dose, how much you got until now. There is like accumulation. Okay, now if you use multiple ototoxic drugs, it also will increase your risk for ototoxic damage. So let's call it co-admin of ototoxic drugs. Next thing is how much you are susceptible for damage from ototoxic drugs. For example, if you have mitochondrial damage, so let's call it genetic susceptibility, how much you are susceptible for damage from those drugs. Now, we are maybe the most common drugs, antibiotic drugs known for being ototoxic are the aminoglycoside, a group of antibiotics which contain the neomycin, tobramycin, amikacin, streptomycin. All those drugs are in the aminoglycoside family of antibiotics. Remember that aminoglycosides are great for gram-negative bacteria. Therefore, they are good, for example, for treating UTIs where you have gram-negative bacteria like, I don't know, E. coli, Klebsiella, and so forth, so on. So the very dangerous antibiotics in it are the streptomycin, which can be ototoxic. For example, around 4 to 15% of patients who receive 1 gram per day for more than 1 week develop hearing loss, measurable hearing loss, and it usually occurs after a period of getting the drug and slowly worsen as the treatment is continued. So streptomycin is one antibiotic like that. Neomycin. Now neomycin, you can find it sometimes even in ear drops, for example, Desoren, for example, Dexotic. Those eardrops can have neomycin in it, and now neomycin is ototoxic namely prohibited, let's say like this, if the patient, if we're talking about the drops, prohibitive drops, if they can get inside the inner ear, namely if the tympanic membrane is perforated. So if the tympanic membrane is perforated, it's better not to give the patient any drops, ear drops with neomycin, because it is ototoxic. Now, it is also not good to give it for a patient too much for IV antibiotic, and not for irrigation of wounds, which can cause the accumulation of neomycin in the body, and from the body it can go to the ear, to the inner ear, and we really don't want it to get to the, I don't know, to the cochlea and cause damage to the inner ear. Of course, we don't want that. Okay, so neomycin, streptomycin, now kanamycin and amikacin. Kanamycin and amikacin are also from this family. Next one is gentamicin. Again, all those cinim, tobramycin, tobramycin. Another antibiotic that can be problematic is vancomycin. Now it's more glycopeptide, which is good for treating gram-positive bacteria. For example, I don't know, MRSA, I think it can cover. Anyway, gram-positive bacteria. It can also cause ototoxic damage. Azithromycin rarely can cause it. Rarely, it is not a common manifestation. Now, there are chemotherapy that can cause it, chemos, especially the platinum containing, which are, for example, cisplatin, or I don't know, everything with platin. So, for example, also carboplatin. Those are also ototoxic. Other drugs are, for example, the ethacrynic acid. I don't know that one, but the next one is a furosemide, which is very common for treating CHF exacerbation, fluids in the lungs, like in pleural effusion. So furosemide, when given in IV, sometimes can cause hearing loss. Salicylic acid is known as salicylates. Maybe the most common one is in the aspirin. It can cause hearing loss, especially in high doses. And the book says that more than 325 milligram of aspirin per day. Yes, so we need to get to a very high dose per day needed to cause temporary, note, temporary hearing loss and tinnitus. So it's temporary hearing loss and tinnitus. Now the other drug is the quinine, sometimes, for example, treating it for rheumatic diseases, for arthritis. So quinine can also cause it, temporary hearing loss. Prevention is, of course, not using ototoxic drugs when can, not treating patients with renal failure, or being very strict in the amount of aminoglycoside they get, and getting it in no high rate of infusion, no high dose, and getting it very under supervision. If the patient has renal failure, so may be more concerned, be more sensitive. If the patient has mitochondrial DNA mutations, so he is more susceptible to aminoglycoside ototoxic effects. So if he has these mitochondrial DNA defect mutations, so more susceptible, more sus to ototoxic from aminoglycosides. So be aware. Okay, this was about medications that are ototoxic, drug-induced ototoxicity. Thank you very much. If there are any mistakes or corrections, please tell me. Thanks for Merrick Manual Professional Edition. I used the book for this, and thank you very much, and that's it.